Hi, everyone. We'll go ahead and get started. My name is Jackie Rao, and I'm the program manager for the Michigan Collaborative for Type 2 Diabetes. We're very fortunate to have Dr. Jonathan Gabison here today, who is an assistant professor here at the University of Michigan and works within family medicine. Prior to that, he went to medical school at the Albert Einstein College of Medicine in Bronx, New York, and did his residency at the University of Michigan. Today, Dr. Gabison is going to be giving us an update on the clinical applications of the new ADA, EASD, and AACE guidelines. I'm going to hand it off to him shortly, and you can feel free to put questions in the chat at any time during the presentation. Dr. Gabison has left plenty of time at the end to address any and all questions that you have. As a reminder, attending this does count for your physician level learning community requirements, so we will be sure to make sure we track that for you. However, if you joined by phone, please email our admin assistant so that she can track that for you. We can't tell when someone's joined by phone. So I'm going to put her email in the chat if you did join via phone so that you can reach out to her and let her know, and we can make sure your attendance gets tracked. And with that, I will hand it off to Dr. Gabison.
Thank you, Jackie. Hello, everybody. I'm Jonathan Gabison. I have, one second. I have no disclosures or conflicts of interest to report. I'm here to talk to you today about these updated clinical updates. The new guidelines have several helpful infographics that discuss a more holistic approach to diabetes management. Ultimately, our goal for treating diabetes is to prevent complications and optimize our patients' quality of life. And there are several individualized factors that play a role in affecting these goals. You are not supposed to be able to read this, but in a pinch, this is a really nice table to have available to see the different characteristics of the anti-hyperglycemic medications in the different classes. So today I want to focus on these 4 specific actions that we can take to help optimize an individual's diabetes. And I'm going to do this through 2 specific cases. So the first case focuses initially on weight management. This is JL. He's a 47-year-old male, has history of fatty liver disease, type 2 diabetes. His BMI is 50. He weighs 383 pounds. He has obstructive sleep apnea, chronic knee and back pain. Currently, his medications are metformin, 500 milligrams daily, and sitagliptin, 100 milligrams daily. His labs at his initial visit, his A1C was 7.0%. He had elevated ALT and AST. His total cholesterol was 204. His triglycerides were elevated to 227. His HDL was 42, and his LDL-C was 117. He presented to clinic on that day interested in losing weight. So just to give a little bit of a background for JL, he has a high-stress lifestyle, and he tends to compensate for that by emotionally or stress eating. He uses alcohol as another coping mechanism. He has a tendency towards binge eating. He has issues with portion control, and he always feels like he's hungry. He's not using a CPAP machine because his mask wasn't fitting him well, and so his obstructive sleep apnea is not adequately being treated. Weight loss is a very important target for treating diabetes. So if one loses 2 to 5% of their weight, it reduces their fasting blood sugar and A1C. If they lose 5 to 10% of their weight, their metabolic function improves. And for this, you think about their blood pressure and cholesterol numbers, as well as blood sugars. If they lose 10 to 15% of their weight, it can have a disease-modifying effect and lead to diabetes remission. Not only that, but weight loss at that level would improve sleep apnea, fatty liver disease, and reduce mortality in major cardiovascular events. For JL, losing 5% of his body weight is 15 to 20%, 15 to 20 pounds. 10% is about 35 to 40 pounds, and 15% is about 55 to 60 pounds. When thinking of treating a patient with obesity, we're starting to have a lot of tools at our disposal. We often like to start with lifestyle interventions, dietary recommendations, and that has been shown to lead to 5%, 10% weight loss. We can do prescriptive nutritional interventions, thinking about meal replacement diets, intermittent fasting, or a specific diet, and that can lead to improved weight loss goals. Thinking about pharmacotherapy, so with patients with a BMI greater than 27 and a comorbidity, or a BMI greater than 30, we can see up to 20% weight loss with certain medications. And then you think about procedural interventions like endoscopic procedure or bariatric surgery that can lead to larger weight loss goals. With bariatric surgery, the indications are a BMI greater than 35 with a comorbidity or a BMI greater than 40. With each one of these interventions, as you go up this pyramid, the risks are a little bit higher. With medications for controlling diabetes, I like to separate them into how they affect our weight. If you look at the column on the left, right, the weight loss, the anti-hyperglycemics that are associated with weight loss. You see metformin, the SGLT2 inhibitors, the GLP-1 receptor agonists, and now there's a new medication on the market that's a GLP-1 GIP dual agonist. Those all lead to weight loss, and all of those medications do not cause hypoglycemia. When you look at the column on the right, the medications that cause weight gain, specifically sulfonylureas and insulin, right, have a high risk of hypoglycemia. And so intervening with these medications that lend towards weight loss, lend towards improving their overall lifestyle and their other comorbidities, we can be helping them in other ways. The GLP-1 receptor agonist, the mechanism of action is threefold. It increases satiety. It sends a signal to the brain to make people feel full. It slows down gastric emptying, and that's usually where we see the most side effects of the medication. And it improves insulin efficiency. The biggest side effects for the medication are GI related. So we think about nausea and vomiting, which happens about 5 to 10% of the time. And then we think about diarrhea or constipation as well. The biggest barriers for the GLP-1 receptor agonists are that they're injectable medications and their cost. I was honestly, when I first started thinking about prescribing them, I was adverse to doing it because I thought people would be turned off by having to take an injectable medication when there are oral options available. But then I realized how small these needles actually are. And even some of these medications have auto-injectors that simplify the process. The fact that semaglutide and dulaglutide, Ozempic and Trulicity, also have additional positive outcomes for cardiovascular health and diabetic kidney disease, as well as the weight loss benefit, it seems like an easier choice. It also helps that starting these medications can help reduce the other medications that they're on, including insulin. The contraindications for this class of medication are if they have a history of medullary thyroid cancer or a family history of MEN2 tumors. And another thing to think about is that Ozempic has been shown to be more beneficial compared to Trulicity, so semaglutide compared to dulaglutide in proliferative retinopathy. The MCT2D website has a really handy resource to help with dose escalation for GLP-1 receptor agonists and SGLT2 inhibitors. Typically for GLP-1 receptor agonists, I increase the dose every month as tolerated to maximize the therapeutic benefits and the potential for weight loss. If they're not tolerating the medication, if they're having the GI side effects, I will keep them at the lowest effective dose. Again, MCT2D has a really good resource on which medications are covered by which insurance companies. And if it's not covered by their insurance, there's really good resources on the website on patient cost assistance tools that each company may have to support patients' needs. Tirzepatide was newly approved for type 2 diabetes. This is the GLP-1 GIP dual agonist. It was newly approved in June of this year, and it's currently being investigated specifically for its weight loss benefits. It's been shown to have similar A1C effects compared to the other GLP-1 receptor agonists and weight reduction. And we don't have cardiovascular data quite yet. There's an ongoing trial. It is not, tirzepatide is not preferred by most insurance plans right now, but as it does get on formularies, MCT2D will be updating the coverage guide over time. And right now it's covered by Humana, HAC, and Express Scripts National. So then I think it's also important when we're talking about diabetes and weight management to talk about metabolic or bariatric surgery, which can be considered a treatment option for type 2 diabetes. The new update mentions that there's a strong association with the duration of diabetes and the likelihood of postoperative diabetes remission. This essentially means that, the longer one has diabetes, the less likely they'll go into remission after metabolic surgery. It still will likely improve their diabetes numbers. And again, the indications for bariatric surgery are here too. Nutrition is one of the most challenging subjects to analyze and discuss with patients. It's between having limited time to focus on and really understanding how to get the right information from a patient to be able to help them modulate their nutrition. It's also really challenging to parse through the nutritional literature out there. For example, there are people who think that eating 3 meals a day and having 2 snacks a day is good for diabetes control, when the evidence doesn't necessarily support that. There is evidence that shows time-restricted feeding can be something to consider as part of a nutritional strategy. And the clinical update talks about 2 eating patterns that do have evidence, which are the Mediterranean diet and a low carbohydrate diet. It's also really important it's really important to think about how we would alter medications based off of nutritional changes, especially if someone is on hypoglycemia causing medications. If interested during the question section, I can discuss my personal approach when talking with patients. This is another handy infographic from the clinical update discussing activity and sleep for patients with diabetes. So the green arrows here signify strong evidence. The yellow arrows signify medium evidence, and the red arrows signify limited evidence. Any activity better than before is good for your diabetes or good for your glucose management. The more you do, the better. So looking here, you see the moderate to vigorous activity improves everything here across the board, from blood pressure to A1C, lipid management, mood, quality of life. Weightlifting or strengthening has been shown to improve A1C. There's strong evidence for that. But you see here that there's still limited evidence that shows a benefit, even if for someone who's not active, to do something as small as standing up regularly throughout the day can have benefits on their glucose management. Studies show that sleep quantity is really, really important. It's not length necessarily, because we see that if you sleep too long, more than 8 hours, or too short, less than 6 hours, it can have a negative impact on your A1C. Sleep quality is really important too. Irregular sleep leads to poor glycemic levels. And so for this, we think about insomnia, obstructive sleep apnea, restless leg syndrome in our patients with type 2 diabetes. With my patients with type 2 diabetes, I typically screen them for obstructive sleep apnea. And I have 3 questions that I typically ask. Do you snore? After getting a full night's sleep, do you still feel tired the next day? And has anyone observed you stopping breathing or an apnea episode while you're sleeping? Those are the 3 subjective measures. And then everything else, we should have the data in our charts, right? Do they have high blood pressure? What's their BMI? Age, gender, and neck circumference is an objective measurement. So let's get back to our patient. For JL, we started him on semaglutide in March, and he tolerated it well. Because we started him on a GLP-1 receptor agonist, we stopped his sitagliptin. Sitagliptin is a DPP-4 inhibitor, and DPP-4 inhibitors help increase endogenous GLP-1. They do not work well together, the GLP-1 receptor agonist and DPP-4 inhibitors. So we started him on semaglutide. We changed his mask from a nasal mask to a full face mask, and that improved his adherence to CPAP. He decided to work on doing a low carbohydrate diet. Our goal was 50 to 100 grams per day. In August, in our follow-up visit, he was down to 326 pounds from 383. That's 57 pounds. His A1C went down from 7% to 5.7%. His liver enzymes normalized, and his cholesterol panel looks really beautiful. So the next case, I want to focus on cardiovascular risk factor management and cardiorenal protection. This is PV. He's a 64-year-old male, has type 2 diabetes. His last A1C was 8.7%. He had a below-the-knee amputation in 2017, moderate diabetic retinopathy, neuropathy, history of a CABG in 2003, and his current weight, or at the time of this visit or this presentation, was 285 pounds. He was admitted to the hospital for an NSTEMI in March. His current medications included long-acting insulin, 40 units every night, metformin, 1,000 milligrams twice a day, exenatide, which is a GLP-1 receptor agonist, 2 milligrams every week, lisinopril, and amlodipine. He previously tried glyburide, which is a sulfonylurea, and then in 2016, insurance denied dulaglutide and liraglutide. Our focus in thinking about cardiovascular risk is going to focus mainly on antihyperglycemics, but the updated guidelines also discuss blood pressure and lipid lowering goals, as well as use of antithrombotic medications. I do want to focus a little bit on dyslipidemia, because it's typically the worst controlled cardiovascular risk out of the diabetic ABCs. This table is really handy in helping assess diabetic patient risk profile. So a high-risk patient is a type 2 diabetic with a duration of less than 10 years, with less than 2 additional ASCVD risk factors, so including dyslipidemia, obesity, hypertension, sex, smoking. Our lipid goal for this patient is an LDL-C A1C of less than 100 or a non-HDL cholesterol of less than 130. And here we would recommend starting on a moderate intensity statin and intensifying as necessary to meet those goals. A very high-risk patient is a type 2 diabetic greater than 10 years of duration and an age over 40, or they have more than 2 ASCVD risk factors. For this patient, our goal should be an LDL-C of less than 70, a non-HDL-C of less than 100, and we would start a high-intensity statin and possibly add, I can never pronounce it, ezetimibe, there we go, or bempedoic acid to reach our lipid goals. Extreme risk patients are those with established ASCVD or severe end organ damage. And for these patients, or signs and symptoms of heart failure, and for these patients, our goal would be LDL-C of less than 55, non-HDL cholesterol of less than 90. And to reach these lipid goals, we could consider adding a PCSK9 inhibitor. In the 2019 diabetes update, they really focused on GLP-1 receptor agonists for cardiovascular risk and SGLT2 inhibitors for heart failure, particularly those with low ejection fractions. But since 2019, additional cardiovascular, kidney, and heart failure outcome trials have been completed, particularly for the SGLT2 inhibitors. This slide here helps summarize these new findings. So if someone has cardiovascular disease or is at high risk for cardiovascular disease, a GLP-1 receptor agonist or SGLT2 inhibitor would be beneficial. If they have heart failure, an SGLT2 inhibitor would be a good option. If they have history of stroke, we would think about GLP-1 receptor agonist or pioglitazone. And if they have chronic kidney disease, an SGLT2 inhibitor is a really good option as well. So PV is an excellent candidate for an SGLT2 inhibitor. SGLT2 inhibitors have a moderate effect on A1C. Typically, it will have a positive effect if their A1C is lower than 9%. If higher, there may be a component already of glucosuria, and so adding to it doesn't necessarily do much. But that being said, SGLT2 inhibitors will have benefit for chronic kidney disease and cardiovascular disease, even if it's not having glycemic benefit. Both Invokana, which is canagliflozin, and Jardiance, which is empagliflozin, reduce major adverse cardiovascular events and have a positive impact on heart failure. SGLT2 inhibitors can help drive weight loss. The biggest side effects are risk of mycotic genital infection, and then there's a rare risk of DKA. So typically, what we recommend for these patients is being careful with carbohydrate intake. And if you're on an SGLT2 inhibitor, we do not recommend going less than 100 grams of carbs per day. However, the guidelines report, or the update reports, that the rate is rare and compares similarly to placebo in the cardiovascular outcome data for DKA risk. In general, the data have increased confidence in the safety of the SGLT2 inhibitors as a drug class. Initially, there were safety concerns for AKIs, dehydration, orthostatic hypotension, increased risk of amputation and fractures. But with long-term studies, they have not seen a significant imbalance of these risks. The GLP-1 receptor agonists have also been shown to prevent major cardiovascular events, specifically dulaglutide, liraglutide, and semaglutide. And they have also been shown to help prevent progression of diabetic kidney disease. So for PV, after his hospitalization, the cardiologist recommended adding dapagliflozin, Farxiga, 5 milligrams. The PCP started the medication 1 week after the hospitalization, and he started cardiac rehab in April. His next visit was in May. He was tolerating the dapagliflozin well. He had 17-pound weight loss, and his A1C went down from 8.7% to 7.4%. His insulin use was going down, so it was down 3 units per week. And currently at this visit, he was at 8 units daily with fasting blood glucoses ranging from 100 to 130. At this visit, the PCP switched him from exenatide to dulaglutide for proven cardiovascular benefits. At his next visit in October, he was tolerating both the dapagliflozin and the dulaglutide, and his A1C was now down to 6.2%, so from 8.7 all the way down to 6.2% in the 7 months. He was completely off of insulin at this point. He graduated from cardiovascular rehab, and he continues with pool aerobics 3 times weekly. I think it's important to highlight that there's still a place for insulin in diabetes treatment, right? First and foremost, if someone is symptomatic of their diabetes, so they have severe hyperglycemia, they have acute glycemic dysregulation, or if we suspect type 1 diabetes, we should be starting them on insulin. If they don't meet their A1C goals, it's something that we can consider as well, especially if they're on these non-hypoglycemic causing agents, the GLP-1s and SGLT2 inhibitors, or if they don't tolerate these medications for some reason. The clinical update also talks about blood glucose monitoring recommendations. So in individuals on insulin, CGM results in better glucose control, fewer hyperglycemic and hypoglycemic episodes, and overall improvement in diabetes distress. There's also a lot of thought about use of CGM as a motivational tool for those that are not on insulin therapy. And there's some modest evidence and anecdotal evidence to support this. We're learning a lot about type 2 diabetes and how to manage individuals from a holistic approach. Diabetes is a really complex disease. There's a lot of psychosocial factors that play a role. And we found that several lifestyle interventions, as well as anti-hyperglycemic medications that can have an effect on one's diabetes management. The challenge is how to use those tools to improve an individual's health experience. And I'm ready for any questions you guys have.
Hi, Dr. Gabison. There's a couple questions that have been submitted in the chat that I will read to you, and then we can open it up. There was a question about the final patient case that you showed. There was a question about why there wasn't, or that there was no CGM in this scenario, but noting that there was good success regardless. I don't know if you want to speak to why you didn't use a CGM with that patient.
So it wasn't originally my patient. There was insurance coverage issues at the time. He was only using insulin 1 time a day. And that was an issue at the time.
Okay, thank you. There's a clarification where someone thought that the recommendation for statins was for all patients with type 2 diabetes, regardless of lipid profile, even if the lipids were quote unquote normal.
Say that one more time, Jackie.
Thought the recommendation was for statins in all patients with type 2 diabetes, regardless of the lipid profile. Though it looks like Dr. Ashman did respond to this in the chat saying regarding statins, the 2022 ADA and EASD didn't change anything about it. They were more focused on hyperglycemia treatment in the context of ASCVD. So the 2022 guidelines suggest that for people without ASCVD who have type 2 diabetes and are between 40 and 75, they recommend moderate intensity statin therapy and lifestyle therapy. So I don't know if you have anything you'd like to add to that.
I have not seen a patient that wouldn't require a statin initially based off of those guidelines. I haven't seen a patient with type 2 diabetes with an LDL-C of less than 100. So typically it would apply for every patient.
Great. The last question in the chat is, if cost and coverage was not an issue, which GLP-1 would you prescribe to patients?
It's a really good question. It really does depend on what my goals are. So there's been a big issue recently with semaglutide coverage. One of the issues is that it was recently, or last year, was approved for weight loss as Wegovy, and it became a very popular medication. And one of the ways that it's hard to find nowadays for patients, but because of the weight loss benefit, I typically start with Ozempic, and it's also good for the diabetic retinopathy. Honestly, semaglutide, dulaglutide, and liraglutide are all really good options because they have those cardiovascular benefits and diabetic kidney disease benefits, and they all have effect on weight loss. And I see Dr. Engelman's comment. So for those patients, if their LDL is in the 50s, I wouldn't recommend starting them on a statin medication. I just haven't personally seen that.
Okay, and those were all the questions in the chat. People can please feel free to unmute and ask their questions, or if you have additional questions about the guidelines changes or anything else Dr. Gabison covered, please feel free to put those in the chat or unmute and ask them.
I have a quick question for Dr. Gabison. I did send this through in the chat directly to you. We had a patient come into the hospital, type 2 with DKA, had just started SGLT2. She did have salmonella infection. So she had taken a dose, maybe 2 doses, maybe 3 doses before she came in. Would you have put her back on the SGLT2, or would you have blamed the DKA on that and hesitated?
Okay, so I would probably give it a little bit of time and see what's going on with their sugar levels. So, there's like a few thoughts that I have in this specific situation, right? So she has an infection that's going to drive her blood sugar levels higher, right? What was her blood sugar levels at the time? Like, what were, like, before being put on the SGLT2 inhibitors, what was going on with her? Did she have really poorly controlled diabetes at the time?
Yeah, she had kind of took a turn for the worse, and A1C was like 9.2%.
Okay. And was she on any other medications?
Yeah, at the moment I can't remember. I think she might have been still taking metformin. She had a GLP-1, and now for the life of me, I can't remember what she was on. I just remembered she had just restarted. She'd been on SGLT2s previously, like years prior, but she did the low carb diet and was very successful, and then just kind of fell off the wagon. And I'm not sure if they had her back on. I think they were having insurance issues with Ozempic.
So the way that I would think about it is putting her on the SGLT2 inhibitor isn't urgent, right? And so, she's in a DKA episode, so I would probably first work to regulate that. That is up there with hypoglycemia. It's the worst thing that can happen. And I would work to modulate that. I would probably try to get her again on a GLP-1 receptor agonist to see how she does with that. Right. And then consider the SGLT2 inhibitor. I'm really, the data on DKA and SGLT2 inhibitors, it's very rare. And so if we have another agent that can be helpful, I would try to get her on that agent first, see how she does, and then consider it again in the future. If she was doing something like a keto diet when this happened, which I'm assuming she wasn't doing,
correct,
then I would work on modulating some of the nutritional.
Yeah. Okay, thank you for that. And somebody did throw a question up there about stopping hyperglycemic anti-hyperglycemic meds in the inpatient. Yes, we did. It was just my suggestion of how to talk with her primary care when she left the hospital on whether or not I should suggest to her to go back on the SGLT2 or still keep working on the insurance coverage for the GLP-1. That was one thing she was fighting with, and she wanted that back on board. So it was just more of a matter of outpatient. Should she go back to that? Thank you.
So that, like, I think that's the advantage of being outpatient doctors, is that we have time on our side for the most part, right? We can work to optimize over time.
Yep. Yeah, I appreciate that. I just wasn't sure what to suggest to the primary care and wanted to support her in what she wanted. She was just getting frustrated with insurance and feeling like her PCP was dragging their feet a little bit. So she was eager to get something done.
I really like I know I'm advocating for MCT2D, but the resources are really awesome in terms of how to get some of these medications covered.
Yep.
And so I might send a link to the PCP in that situation.
Perfect. Thank you.
There's,
oh, sorry, Jackie.
I was just gonna say, there was another question in the chat during that question. Is it still recommended to hold oral anti-hyperglycemic agents in the inpatient setting, such as metformin, or is this an outdated practice?
From my reading, it is outdated. If they're coming in with a kidney injury of some sort, then you should hold metformin.
Anyone else have any other questions that they want to either put in the chat or unmute and share?
Yeah, I'll just unmute, I think, as a follow-up to that last question or comment maybe about insurance. Like, for a patient for which the guidelines say an SGLT or GLP is recommended, but you cannot get it, how does that affect then your next choice of medication?
So I have not come across that situation, especially now that Medicaid and Molina and all these insurances are covering it. I would really advocate to get them covered. If a situation where it's not covered and they are poorly controlled diabetic, I would talk a lot about nutritional changes, lifestyle changes, and then this is a situation where we need to use other medications possibly. But sometimes I really like to use the disadvantages that the system puts in front of us as a motivational tool to talk with patients about those lifestyle changes. So the system, and it also can make us feel like allies because we're trying to reach the same goals, the patient and the doctor.
A question from the chat, any ideas about coverage for obesity without diabetes?
So it depends on the insurance. Some insurances are covering anti-obesity medications. Thanks to the advocacy of Dr. Oshman, actually, who just spoke, Medicaid covers anti-obesity medications in Michigan. You know, there's different strategies on how to approach it. So the short answer is that there are essentially the 2 GLP-1 receptor agonists that are approved for obesity. There are 2 oral tablets, Qsymia and Contrave, approved for obesity. And then there's phentermine and orlistat. If none of them are covered, you can consider splitting up Qsymia, which is phentermine and topiramate. You can consider splitting up Contrave, which is naltrexone and bupropion, and seeing if that is going to have an effect or a positive effect, because those are all generics. It's hard, right? I think the good news is that I feel like this is changing, right? And more insurances are covering these medications, and yeah.
Okay, final call for any questions, either in the chat or again, please feel free to unmute and just say them out loud. Okay, well, thank you everyone so much for joining today, and thank you, Dr. Gabison, for leading today's presentation. As I mentioned in the beginning, but if people have joined since, if you joined by phone instead of via your computer, please make sure to email our admin assistant so that we make sure that we can track your attendance to give you learning community credit. I just put her email in the chat once again. We'll share the slides with everyone, and we'll also share a recording of this later in case you want to share it with others on your team. And we really appreciate you taking the time to be here today. And again, thank you to Dr. Gabison for leading this presentation. Great. Have a great afternoon, everyone.